Let me just quickly correct some impressions.
Okay.
You cannot, and I'm going to bring in a scenario Dr. Akinjobi said, you cannot get a payment for your vehicle that's ran into a ditch when you're not insured. So the first thing is that you have to register on that scheme. If you're not registered, the government does not see you. You're not coming on the platform. That's number one. Number two, if you register, you'll be given a card which you can use to access health services at a nearby hospital of your choice. Okay? Now, the issue of drugs, it is not the NHIS that buy drugs for you.
Okay.
And neither is, you see, when we're talking about health services, I don't sell drugs. You understand? What you can do is to sell the service. If the drug is part of the services, then you can get it. And what is obtainable now is that we'll give you a prescription. You understand? You take it to the pharmacist because the chain. You take it to the pharmacy and you get a 10% co-payment. I mean, if the drugs cost 100 naira, they will ask you to pay 10 naira, and the pharmacist will take your paper and give you the drugs and send, and the government will pay you 90%. That is how it works.
Okay.
Because people need to be well.
So there's a chain. As you go to a hospital, you get diagnosis service, you now get prescription.
The same thing goes to the lab.
Okay.
If I need to confirm my diagnosis, you understand? I send the patient to the lab, you understand? The lab complements my impression by taking blood or samples to confirm the diagnosis. By the time the patient comes back, I see the result, I write a prescription. You take it to the pharmacy. I mean, these are the things that we need to get to understand. And that's why I'm saying it's a unifying system.
But it's not clear. The pharmacist within the same value chain.
It can be within
outside.
It has to be under the
scheme.
Under the scheme.
Usually we have the primary provider. It's the first port of call when a beneficiary or enrollee you want to access help. And when he gets there, he's the one that will start up with him. And if there's need for referral, you could refer him, make prescription and ask him to see the pharmacy, or you could make a request for laboratory testing and ask him to see the laboratory. And you still have to come back to him, and then you have to finish.
Alright, I need to ask about statistics. Do we have available statistics? Because that person wanted to know also how many people so far, because people will question the genuine of the statistics.
We said that 4% of Nigerians are captured.
Just 4%. 4%.
Yes. So it means that largely many Nigerians are yet to be into the scheme.
Under the former. Because very sparring numbers are under informal. We have pockets of people that have started community health insurance. We have a pilot studies in Lagos. On the Lagos Island, there are people that have started a community-based health insurance scheme. You understand? They don't even wait for NHIS. What they do is to set up a community group, MHA, you understand, which they pay for as an HMO. And like I said, the HMO also are marketers. They have their marketing strategy. They can go to all the mechanic in Lagos Island, for instance, say, come and pay a token. We will have lists of hospitals that you can go to when you have it. And once you pay it regularly, you get your service.
Okay, but I'm thinking, should we change the approach a bit while we're talking about, making this scheme better and more workable for Nigerians? I'm thinking, Nigerians like this Isusu, Ajo kind of thing. Maybe if there's return on investments, I'm just thinking out loud. It is not.
All this rumination, all this mental tasking are also been going on in nature. In fairness to them. And that's why at the point is that they came on that look, if 90% of Nigerians have an access to phone, because it's very, you won't remember to pay your premium. You understand? But once you recharge, you understand, and you're under that scheme, that money will be.
You need to make it attractive because for a lot of Nigerians, this is just another money.
That's why that product. That's why
Yes. Because I really need to understand, because you've laudably said how wonderful it is. So you say you pay about 8,000 naira or 12,000 naira every year. And are you saying that if I don't default, because the way insurance works in my head is that you pay premium on a regular basis, what happens when you default in payment? Does it in any way negate the fact that you can't get complete health care?
You see, the truth about it at the beginning, once you make your premium, you wait a month for that paper to go around, get the form, you understand? Once you start, you are paid for that year.
Okay.
And there's a system that tells you that just this is how things are working. You understand? What that means is that if you don't get health conditions in a year, it doesn't mean that you have lost. Some people have, you are paid for some things.
Exactly.
You understand? Of course, a pool.
Okay.
Because actually, what thousand that you're paying monthly is not what your health. So they are pooling. And that was what the Akinjobi was said the other time by saying that, look, forget about that your workers or somebody, that money has been used for somebody else. You understand? Which was actually the primary idea in Germany when this was first built decades ago. You understand? Somebody has to pay for somebody else, at least to make the environment healthy for everybody.
Or what they call other people's money.
Money
in the business world. Yes. That's what it is. And then that calls to mind the fact that if you have more people on the scheme, it will become cheaper.
That's why it's only benefits. Let me tell you one thing. The providers are also sacrificing a lot. What besides any provider that has 10 enrollees? Because they're going to be, the NHI is going to be paying you for 10. But if I have one provider, I mean, when I was still the chairman, a lot of complaints come. I have 10 enrollees, 6 of them are hypertensive, 4 is diabetic, and they are coming every 2 weeks. And they're giving you a token. I mean, you cannot factor it because they will use more than what they are giving to you. And that's why we are saying that, look, the current executive secretary must look into the volume before any provider starts.
So it's more than there.
You understand? Okay, a situation, we've had a situation at one point in time where Gwagwalada Hospital was sending out, they said they are overwhelmed. There's no reason why Gwagwalada Hospital must be overwhelmed when we have a lot of private providers in that department. You understand? You will get a tertiary case. And that's where Igwe was talking the other time when we were saying that there's some cares of services, primary, secondary, and tertiary cares. If you come with a primary care, there's no need to go to teaching hospital. You have a primary provider. Why do you have to go to? Because when they fill up their beds with those primary care, level of care in those teaching hospitals, when the stroke comes, they won't be able to have a bed. So we need to streamline all the system and see how to keep talking and keep talking. The NHIS has to get the providers to be involved in information, in policy making.
Then structure-wise, have you gotten it right?